Hi everybody, this is Jen Sibley. I'm presenting on Henoch Schönlein Purpura this week. I hope you enjoy my presentation. So I'm going to start with a case study here. In the subjective data of our case study, we have a 7-year-old male presenting to our clinic with a chief complaint of rash. The HOPI reveals that the rash originally started out on his buttocks 1 week ago as small itchy bumps, which his mom disregarded as irritation from the net inside of his bathing suit after a day at the beach. The rash progressed to become dark purple, and the spots seemed to merge together and spread down to his legs and feet. The patient has also had complaints of stomach pain since yesterday, and his appetite has decreased. He has had nausea but no vomiting until he was in the car on the way to this appointment. And the patient also says that both of his knees and elbows are hurting. His past medical history reveals no hospitalizations or surgeries, no allergies, no meds. Birth history, he was full term with a normal vaginal delivery and no complications. Immunizations are up to date. Family history has no history of bleeding disorders or hereditary illnesses. Social history, he's just completed the first grade, lives at home with mom and dad, has no siblings and no pets. And review of systems reveals an upper respiratory infection about 10 days ago that is now resolved, and no current problems with congestion, cough, fever, diarrhea, or constipation, and no blood in his stools or urine. The physical exam reveals a weight of 30 kilos with vital signs showing heart rate 100, respiratory rate 20, BP 98/60, temp 98.9, and O2 sat 99%. The patient appears non-toxic, although uncomfortable and tearful while lying on the exam table. His skin reveals palpable purpuric lesions of varying sizes noted over buttocks, lower extremities, and feet. And he also has edema over both knees and elbows. There are no lesions noted on the trunk, back, arms, hands, face, or neck. His skin is otherwise warm, dry, and intact. Respiratory-wise, his breath sounds are clear with no audible wheezes, crackles, or rhonchi. No signs of symptoms of distress. ENT reveals that TMs are gray bilaterally. Throat with no erythema or petechiae, no tonsillar hypertrophy, no nasal congestion noted, and his inferior turbinates are pink and not enlarged. Cardiovascularly, he has no murmur audible, normal S1 and S2, pulses are 2+ in his bilateral upper and lower extremities. His abdomen is flat with active bowel sounds, soft but slightly tender on palpation. No masses, no hepatosplenomegaly, and no CVA tenderness. GU, his testes are descended bilaterally with no scrotal edema or pain noted, and he is circumcised. Musculoskeletal shows arthralgia and edema in both elbows and knees with limited active and passive range of motion due to discomfort. This is a picture of the purpuric lesions seen on a child's feet and backs of his ankles. And here is another angle of a picture of lesions also on the child's foot and inner ankle. So let's take a break from our case study and talk a little bit about Henoch Schönlein Purpura. This disorder is also called IgA vasculitis and is often abbreviated as HSP or IgAV. It is an immunologically mediated purpuric, non-thrombocytopenic, and systemic vasculitis involving the small blood vessels of the skin, GI tract, joints, and kidneys. Henoch Schönlein Purpura is the most common form of systemic vasculitis in children. 90% of all cases are in the pediatric age group between ages 3 to 15 years old, with a mean age of 6 to 7 years old and a slight male predominance. It is self-limited in the majority of cases. It is characterized typically by two of the following: palpable purpura without thrombocytopenia or coagulopathy, an age of onset of under 20 years old, abdominal pain, and granulocytic infiltration of vessel walls, which causes colicky abdominal pain and arthritis or arthralgia. The epidemiology of HSP is that it occurs primarily in the fall, winter, and spring, but rarely in the summer. And that is due to the fact that it is associated with recent infections, and about half of HSP cases are preceded by an upper respiratory infection, especially those caused by Streptococcus. Other triggers include other infectious agents, vaccinations, and insect bites. The pathogenesis of HSP is an immune-mediated vasculitis associated with IgA deposition, but the specific involvement of IgA in the pathogenesis remains unclear. It involves other factors, including immunologic, genetic, and environmental factors as well. The characteristic findings are leukocytoclastic vasculitis accompanied by IgA immune complexes within the affected organs, and skin biopsies reveal involvement of small vessels within the papillary dermis, and predominant cell types within the inflammatory infiltrate are neutrophils and monocytes. The clinical manifestations in children include the classic tetrad of palpable purpura without thrombocytopenia and coagulopathy, arthritis or arthralgia, colicky abdominal pain or GI bleeding in the form of guaiac-positive stool because hemorrhage is rare, and renal disease. It may develop over days to weeks and vary in the order of the presentation of symptoms. Purpura and joint pain are typical presenting symptoms, but not always. Some may present only with abdominal pain and joint pain. The most common skin and GI manifestations include purpura, which begins with erythematous, macular, or urticarial wheals, which then coalesce and evolve into ecchymoses, petechiae, and palpable purpura. They typically appear in crops, symmetrically distributed and located in gravity-dependent or pressure-dependent areas such as lower extremities and buttocks, but may also appear on the face, trunk, and upper extremities in non-ambulatory children. The GI symptoms typically appear within 8 days of the purpura, but may be longer. They typically include nausea, vomiting, abdominal pain, and transient paralytic ileus. Intussusception is the most common GI complication. Renal manifestations typically are more prevalent in older children and adults. The most common presentation would include hematuria with or without RBC casts and no or mild proteinuria. With our assessment, we must consider the differential diagnoses that could be possible in this patient. And here is a list of some that would be likely to be considered in our workup. So there are no definitive laboratory tests that you can run specifically for HSP. However, if you were to draw an IgA level, you may find that it's elevated, as it is in 50 to 70% of patients with HSP. CBC chemistries and UA may also be helpful. They are non-specific, but they can help rule out other differential diagnoses because in HSP, you will always have a normal platelet count and normal coags. And also, if HSP were to follow a bacterial illness, it may show leukocytosis and an elevated ESR on the CBC and the ESR. And the UA may also show hematuria and proteinuria in HSP. If you were to draw complement levels of C3 and C4, you may find that they are low or a hypocomplementemia in HSP if it follows more recent strep infection. And you may also want to consider drawing an ANA if you have a child presenting with nonspecific symptoms of joint pain but not purpura, because you may be thinking of things like juvenile arthritis and other immunological conditions where an ANA would be elevated in those conditions, but if it is HSP, it will not be elevated. And the stool may also be guaiac positive, so you may consider testing the stool as well. Additional evaluation of a patient presenting with the same presentation as our case study could include imaging studies for patients who have significant abdominal pain, such as a KUB, or an abdominal ultrasound may be helpful to help us rule out intussusception or appendicitis. And as you all know, with intussusception, in contrast, enema may actually be indicated in those situations. However, in a patient with HSP who we are suspecting may have intussusception, a contrast enema is actually contraindicated because it may perforate the inflamed bowel, and it also will not reduce the intussusception the way it would normally. Another study to consider could be a Doppler flow study of the scrotum for patients who are presenting with scrotal pain. That would help us rule out testicular torsion. So how do we make the diagnosis of Henoch-Schönlein Purpura? Well, it's based on the clinical manifestations in conjunction with maybe some of the lab studies that I discussed, as well as ruling out other differentials. The ICD-10 code that would be used in this case would be D69.0 for allergic purpura. Other ways to maybe get a more definitive diagnosis of HSP could be to biopsy the skin or kidney in children presenting with incomplete or unusual signs and symptoms, or if there's evidence of severe renal involvement, because that would help us to stage the severity of the renal disease. Biopsy would show that leukoclastic vasculitis with predominance of IgA deposits are present, and that would confirm the diagnosis. But as I said, there are no laboratory tests diagnostic for HSP, but confirmation of a normal platelet count and coags are necessary to rule out other diseases that are also presenting with purpura due to thrombocytopenia or coagulopathy, because remember, in HSP, they have a normal platelet count and normal coags. So for our little man here, our plan will be include management listed below, which in the vast majority of patients, they recover spontaneously without specific therapy, which is wonderful. And the care, therefore, is primarily supportive, where we push for adequate hydration, we encourage rest and elevation of any edematous lower extremities, and provide symptomatic relief of joint or abdominal pain through the use of acetaminophen or NSAIDs. For mild to moderate pain, UpToDate recommends naproxen, 10 to 20 milligrams per kilogram divided BID for adolescents, or ibuprofen, which may be better tolerated but requires more frequent dosing. And in cases of severe abdominal pain, glucocorticoids may be helpful. They may also help relieve the rash or the arthritis and arthralgia and scrotal pain, but it's usually not indicated unless the signs and symptoms are severe enough to impact the oral intake. And the dosing in this case would be prednisone 1 to 2 milligrams per kilogram per day with a max dose of 60 to 80 milligrams per day. So at what point would we decide that outpatient management is not enough and we would need to hospitalize this patient? Well, we would be looking for a patient who's showing us that they're unable to maintain adequate hydration with oral intake, experiencing severe abdominal pain accompanied by nausea and vomiting, having significant GI bleeding, changes in mental status, or severe joint involvement limiting ambulation and or self-care. And also if they're showing symptoms of renal insufficiency, which would be exhibited by an elevated creatinine or hypertension and or signs and symptoms of nephrotic syndrome. Those would all be reasons that we need to send this patient over to the emergency room. Fortunately, the prognosis for these patients is generally excellent. These illnesses typically resolve within a month in the absence of significant renal disease. 2/3 of these children will never have a recurrence again, and 1/3 will have a recurrence at least once, and it typically recurs within 4 months of the initial presentation. And then each subsequent occurrence is generally milder and or shorter than the preceding one. And interestingly, renal involvement is the cause of most serious long-term morbidity, and the worse the renal involvement, the higher the chances of subsequent occurrences. So for comfort with mild to moderate pain, I would recommend ibuprofen oral suspension for our 7-year-old patient here, since he doesn't take pills. And with a weight of 30 kilos and the children's strength being 100 milligrams per 5 mLs, he would need to take 10 per kilo, which is 15 mLs PO every 6 hours as needed for mild pain. And this is available over the counter, but I wrote out the prescription anyway. If he were an adolescent, we could also consider prescribing naproxen, whether it be tablet or liquid form, and that dose would be 10 to 20 milligrams per kilogram divided BID. And that's only twice a day dosing, so that could be an alternative for somebody had he been an older patient. So if our patient was experiencing severe abdominal pain to the point that he could not tolerate taking any PO intake, we could consider prescribing prednisone at a dose of 1 to 2 milligrams per kilogram per day. Our particular patient is not experiencing this type of abdominal pain, so I'm going to hold off on actually writing this prescription for him. If I did want to write it for him, this is what the prescription would look like. With a dose of 1 milligram per kilogram per day, it would 30 milligrams a day or 10 mLs PO daily for up to 2 weeks for severe abdominal pain. Follow-up for our patient would include monitoring for his UA and BP weekly or bi-weekly for the first 1 to 2 months after his initial presentation. And then once the HSP subsides, additional follow-up visits should include full H&P, UA, and blood pressure monthly, and then every other month until 1 year after the initial presentation, and then annually at well-child checks to detect for late renal disease. Serum creatinine should be considered for any patient with significant or persistent urinary abnormalities or elevated blood pressure. And we would refer to nephrology for patients who were showing persistent proteinuria on their UA, hypertension, or other symptoms of renal insufficiency. For our patient and family education, I would definitely take the time to review the disease process and management with the family, considering most people have probably never heard of this disorder. And we also need to definitely reinforce the importance of them being compliant with the recommended follow-up appointments so that we can continue to monitor blood pressure in the UA. We would also teach what signs and symptoms to watch for that would warrant a reason to hospitalize the child, and that would include decreased PO intake, particularly with fluids, unmanaged pain, worsening abdominal pain, GI bleeding, and worsening renal involvement. So that concludes my presentation on Henoch Schönlein Purpura, and here you will find my references followed by my exam questions on the last few slides. I hope you enjoyed my presentation using Adobe Spark, and if you guys have any questions about this software, I would be more than happy to answer them for you. So my first exam question is, a 7-year-old boy presents to his primary care physician with the chief complaint of dark purple rash and joint pain. A CBC and UA were performed and reveal a platelet count of 150,000, white count 7.4, red cells 4.6, hemoglobin 12.3, and hematocrit 36.9. UA reveals trace hematuria and proteinuria. What is the most likely diagnosis? A. Immune thrombocytopenic purpura. B. Henoch-Schönlein Purpura, or IgA vasculitis. C. Hemophilia. Or D. Septic arthritis. The correct answer would be B. The rationale is that a normal platelet count rules out ITP. The UA with hematuria and proteinuria in the setting of purpuric lesions and joint pain and a normal platelet count are consistent with the diagnosis of HSP. And my second exam question is, the following are appropriate in the diagnostic workup of suspected IgA vasculitis except A. CBC, B. coag studies, C. abdominal ultrasound, or D. contrast enema. The correct answer would be D. The rationale is that a contrast enema in patients with signs and symptoms of intussusception and suspected HSP are not indicated because the barium may damage or perforate the inflamed bowel and will not reduce the intussusception that is associated with HSP.